Good morning. First of all, I want to thank the organizers for giving me the opportunity to come back in this beautiful city. This is the third time that I am able to admire Warsaw. My aim is to give you some information about, in my view, a very important new development in gynecological endocrinology, which is the issue that we have understood that antiprogesterone are important tools in our hands for different problems in gynecology, fibroma, bleeding disorders, but also as a tool for emergency contraception. Emergency contraception basically is of interest in our view because we still are confronted with a high level of abortion all over Europe, and we still do hope that with more effective emergency contraception we may reduce this, because this is our main objective. Now the question is, these new emergency contraceptives based on antiprogesterone action, what is actually happening? What are they doing? Are they working on the endometrium? Are they working on the cervix? What are they doing? Because until now we mainly know, of course, what progestin does, but not what antiprogestin do. Now, I will show you studies which will, I think, prove that the main action of these antiprogestins is actually to postpone ovulation. So that they inhibit or delay the follicular development. And this is very interesting and very new, because until now we only understood that you can suppress ovulation, but that with a single treatment you can sort of delay ovulation is something which is really new. And I will show you that this action is still effective at the moment of the LH peak. You know, the LH peak is the signal that will lead to ovulation. There are other mode of actions which have been suggested, and I will go into this, what studies have shown on this issue. I think what we all know is that, you know, if you look at the fertile cycle, you have the follicular phase, you have the luteal phase, which we all know, and you have two major facts. One fact is that the egg cell can be fertilized during 24 hours. And the other fact is that the sperm are able to fertilize an egg cell during 5 days. So the single sperm is able to do that. And this is actually what we are looking into, whether we somehow in emergency contraception can prevent this fertilization to happen. Now, how would we do that? By giving emergency contraception to postpone the ovulation more than 5 days. So if the individual woman had intercourse, that the likelihood here she would probably get pregnant, because there will be an ovulation and there are sperms around. But if you postpone the ovulation for enough days so that the sperm cannot fertilize anymore the egg cell. So this is the basic mechanism. There are other questions. Does an antiprogestin maybe have an impact on the acrosomal reaction? Because we know that progesterone triggers acrosomal reaction. It has been shown that this is not the case. There are some contradictory results. There may be a little impact on sperm, but this will, in this case, is probably not the most important factor. Actually, there are interesting research going on how to influence acrosomal reaction, maybe also as a contraceptive. Is it something that happens in the fallopian tubes? You know that, of course, progesterone has an effect on the mobility of the tubes. it looks like there is a little bit an impact which would lead to less movement, but the fact that there is no indication that there are more tubal pregnancies in the context of emergency contraception is an indirect, you could say, an indirect proof that this is not a major factor. What about the endometrium? Of course, this is quite important, and there have been different approaches to this question. One is endometrial biopsies. There were no important changes when you use LNG. With the antiprogestin, you had a dose-dependent effect in the maturation, in the early luteal phase, but in the second luteal phase there were no changes in menstrual cycle length. And I will show you some studies also which looked into whether it is inhibiting implantation. And there were no findings proving that there is an effect on implantation. Because obviously the effect on embryo attachment in an in vitro 3D human model did not differ to controls. So this is quite important. This is the publication which looked actually into this issue, whether embryo attachment is influenced. And as you can see there, this is the publication by Berger in Human Reproduction. There was no indication that you would have an influence on embryo attachment. There are other indirect clinical issues where they have tried to find out what is the issue of taking the ulipristal in the follicular phase, taking it in the post-follicular phase. And you can see that and I will show you this study in a minute, the efficacy in the follicular phase is much higher when you take it before ovulation, and after ovulation it's no more effective really. And you can also see that if there would be an important impact on the endometrium, you would probably have more miscarriages, which is not the case if you look at the data from the post-marketing data on 1.4 million women exposed to UPA. Now, what happens regarding bleeding pattern, regarding the influence on the cycle itself, if you postpone ovulation, what happens with the bleeding, and what happens if you give this antiprogestin before or after ovulation. And here is a study where they used this emergency contraception 5 days after unprotected intercourse, and they were assessing, was this pre-ovulatory or was it post-ovulatory? And they were looking into what happens to the pregnancies rate and what happens to the menstrual bleeding pattern. And as you can see, the expected rate of pregnancies and the really observed pregnancies were quite different when you looked into the pre-ovulatory and the post-ovulatory state, controlled compared to controls. So this means that effectively the effect is really almost only if you use this in the pre-ovulatory state, because here you really have a significantly lower pregnancy rate versus the expected rate. It's a failure of 1.7%, and of course there are failures and there will always be failures, because if women take it post-ovulatory, it will fail. Important, of course, is the question of safety. If we introduce something new, we know, for example, LNG as an emergency contraception is very safe. We have a lot of experience about it. What about the general side effects? And here, the antiprogestin ulipristal was compared with the well-known LNG, emergency contraception, and you can see that these typical side effects, headache, dysmenorrhea, nausea, were more or less more actually the same. There was not a real significant difference. There are, of course, these post-marketing surveillance studies, which are obliged by the authorities. I think this is very important. And what we know now, in more than 8 million doses of this drug, there is no signal of increased risk of miscarriage. There is no signal of increased risk of fetal or neonatal defects. There is no signal of increased risk of pregnancy complications, including ectopic pregnancy, and no signal of teratogenicity. This is, of course, very, very important that we keep on collecting these data, but based on 8 million, that sounds, I think, quite comforting. This is one of the issues where they were looking into pregnancy, what happened to pregnancies, and it was confirmed what I was just saying. This is pharmacovigilance database, so this is official database, and you could see that there were no complications during pregnancy, no abnormalities, and rates of miscarriages and ectopic pregnancy similar to general population. So that looks like a quite good safety profile. Another interesting and important issue is, of course, is this use of this drug having maybe a negative impact on future fertility. This is very important for young women. And you can see that it is really only an intermittent effect. The woman takes it, the ovulation is postponed, but the ovulation comes. It's not suppressed. And in the next cycle, it comes back, which means that it doesn't confirm any additional protection. So it's really just in the cycle itself. And you can see here, this is a comparison, and Dr. Brache was the most famous researcher in that field, where she was looking into when does ovulation come back. If you take it, you just postpone it, but then it comes back parallel to the control group. This is also true even if you give repeated doses. Here in this study, it was during an 8-week period. Women got several times UPA, but they would not suppress ovulation after the usual postponement. So the ovulation comes back. This is what I got from here. That you have, if you compare the use of Volikristal, it's quite low here in Poland, it's quite high here in France, Norway. I'm coming from Switzerland. We are a small country, but it's quite frequently used. It's over the counter there. So the EMA, the European Medical Association, recommends availability without prescription. Because they were convinced that it is effective and safe. This was given to me, which obviously is the latest data regarding pharmacovigilance. That is an exposure of 200,000 takes, May 2015 to January 16, and there were 30 cases of adverse effects, including 10 cases of unintended pregnancies. And I think that proves that, of course, this will never be a 100% effective drug, because it depends on when it is taken, related to ovulation and follicular phase. This has been, of course, very frequently cited now, whether we have a difference between LNG and Volikristal. You know certainly all about the studies from Cranin and from Glacier, and when they were put together, they did find a difference, which is probably due to the fact that you have with UPA still a postponement of ovulation even at the moment of LH surge, while if you use LNG, you only have postponement of ovulation if you use it before the augmentation of before the LH peak. And here you can see that it looks like that UPA is more effective in preventing unwanted pregnancies, and especially for a longer period of time than LNG. So both studies, Cranin and Glacier, indicated that that even when the intake, which should be taken as fast as possible after unprotected intercourse, as you certainly know, when it is quickly taken, the effect is, of course, the efficacy is much higher. Here you can see the odds ratio. If you look into the comparison to LNG, that it looks like here we have a drug which is more effective in preventing unwanted pregnancies. So this is probably due to what I just mentioned. This difference is probably due to what Brache has shown in contraception in 2013, that UPA is still postponing ovulation at the moment of the LH surge. The LNG can only do it before the LH peak, but after the LH peak, none of them, neither LNG nor UPA, can postpone ovulation, and they are as ineffective as placebo, as this nice study has shown here. This is the graph, the pharmacokinetical data that show very nicely this difference between the placebo, UPA, LNG, where you still have an inhibition of postponement of ovulation even in the moment of the LH surge. Now this information has been put together by the International Consortium for Emergency Contraception. The European Society of Contraception has been involved, and WHO has been involved, to help people to understand that probably what we know now regarding emergency contraception, regarding efficacy, is that the most efficacious is copper IUD, but here we obviously have a possible impact on implantation. Then comes UPA, and then comes LNG. And on this wheel you can see different clinical conditions where you have additional information how to use this, what are the precautions, and what are the safety issues in specific conditions. So the conclusion, I think it is important that we understand that both emergency contraceptives actually delay ovulation, which is the most important mechanism before fertilization. As I showed you, what we know now from post-marketing study, that ulipristal acetate seems to be efficacious and safe. Even after the OTC status, the safety profile is still confirmed. And I can tell you, I mean, that there were also in Switzerland some concerns regarding if it is given over the counter without contact, although our pharmacists are very well trained, couldn't it be used in a wrong way? We didn't have any reports really on abuse of this drug. Also in our hospital, where in the region it's quite frequently used. So it is very important that it has to be taken as soon as possible to be effective, and it gives a possibility to avoid unwanted pregnancy or abortion. And recently, for example, in my practice, what I quite frequently are confronted with, the woman takes the pill, she forgets it, or she has vomited, just at the beginning of the cycle after the 7-day break, with a high risk of getting pregnant, and where we can sort of additionally protect her against pregnancy. This is what I wanted to say. Thank you very much for your attention. Thank you.